Welcome to Screening Neurologic Examination. I am David Lee Gordon, Professor of Neurology. I would like to thank the many people who assisted me in developing this program, especially the neurologists who first helped me develop the contents and format of the Essential Neurologic Exam, Jaffer Khan of Emory University, Stephen Lewis of Lehigh Valley, and Patrick Reynolds of Wake Forest. In addition, the team that helped me create the videos in this presentation, Evan Fields, who played the patient, Olivia Nicole Gordon, who was the videographer, and Adria S. Chappell, who was substitute videographer. And the team that helped edit this presentation was Adria Chappell again and Stephen Clayton. This is the learning objective for this presentation. After viewing this presentation and practicing the screening neurologic exam with feedback from an instructor, the learner should be able to perform a screening neurologic exam in less than 3 minutes using proper technique and, if necessary, a pocket card as a prompt. Providers should perform different neurologic exams for different situations. The screening neurologic exam is designed for non-neurologists to perform as part of a general exam on patients with or without suspected neurologic disease, and for neurologists to perform on all return neurologic patients with previously normal essential exam. It is a quick neurologic exam consisting of key exam components. There are 15 items. It takes about 2.5 minutes, and there are no tools. The essential neurologic exam is a more comprehensive exam. It will not be covered in this presentation. Focused neurologic exams are supplemental exams to be performed above and beyond the essential neurologic exam. They will also not be covered in this presentation. The screening neurologic exam consists of 3 mental status components: level of consciousness, language, and orientation; 4 cranial nerve components: visual fields, extraocular movements, facial sensation, and facial strength; 4 motor components: arm drift, finger tap, hip flexors, and ankle dorsiflexors; 1 sensation component, light touch; 2 coordination components, finger to nose testing and heel to shin testing; and 2 gait and station assessments, regular gait and Romberg. However, for the training of the screening neurologic exam and its performance, we have modified the format for time efficiency into 6 slightly different categories. Mental status stays the same, level of consciousness, language, and orientation, but we have eliminated cranial nerve category and instead have eyes, which consists of visual fields and extraocular movements; sensation, combining light touch over the face and body; motor coordination upper, which includes facial strength, arm drift, finger tap, finger to nose testing; motor coordination lower, which includes hip flexors, ankle dorsiflexors, and heel to shin testing; and no change in gait and station, consisting of regular gait and Romberg. Once again, there are 15 items. It takes about 2.5 minutes, and there are no tools. The neurologic exam pocket card has the screening neurologic exam arranged in this modified format for time efficiency at the top of the card, and at the bottom of the card is the more detailed essential neurologic exam.
Hello, I'm David Lee Gordon, Professor of Neurology. When performing the essential neurologic exam, start with level of consciousness. First, assess is the patient awake, alert, and attentive. Hello, sir. How are you today?
Doing well.
You can see he is awake, alert, and attentive. Decreased consciousness can be described in different ways. The best way is to use regular language, not medical language. Simply say, what is a stimulus that aroused the patient? Awake and alert and attentive is normal. If he were slightly drowsy or sleepy, we might say he has eyes closed, aroused to verbal or stimuli, or aroused to tactile stimuli. Or do you need painful stimuli to arouse? Or does he not arouse at all? So these are the kind of ways you describe level of consciousness. They are divided by some into drowsy or lethargy, which is about the same thing, stupor or coma, but it's best to use just regular language and describe specifically what stimulus aroused the patient.
Tips and pearls for mental status, level of consciousness. Start the neurologic exam by observing the patient's consciousness and describe normal consciousness as awake and alert and attentive to the examiner. Describe depressed consciousness in terms of the stimulus needed to arouse. For example, arouses to verbal stimuli, voice. Arouses to tactile stimuli, touch. Arouses to painful stimuli, such as a pinprick. Arouses to only deep painful stimuli, such as a sternal rub. Coma means the patient has no meaningful response to deep painful stimuli, and meaningful response means an effort to withdraw the pain. It does not refer to reflex actions. Decreased consciousness is due to inhibition of the ascending reticular activating system, or ARAS, via either bicerebral dysfunction or brainstem dysfunction.
Let's now test language. Now, there are 4 components to language testing, but in the essential neurologic exam, we're only going to test one of those components. That's naming, because naming is abnormal in all language dysfunction, all aphasias. And try to use things that are really well known to the patient so that you don't pick dialect or other terms they may not know. The simple thing is using the hand. And start with the big component and go down to the small component, because it's easier to name a large thing and harder to name a small thing. So here's an example. What is this thing, sir?
It's your hand.
And what is that?
Finger.
And what is that part right there called?
Fingernail.
Hand, finger, and nail. The easiest things to use for language testing.
Tips and pearls for mental status, language, or naming. Perform language testing after consciousness assessment and, very importantly, before orientation or any other mental status testing, because incorrect responses on further mental status testing may be due to language difficulty and not true confusion. If naming is abnormal, one must complete language testing by also assessing comprehension, repetition, and fluency. Language dysfunction is called aphasia and occurs with dysfunction of the dominant cerebral hemisphere, which is the left hemisphere in most people.
Only after you have assessed level of consciousness and naming can you then proceed to the rest of the mental status testing. And on the essential neurologic exam, we're only going to do orientation after we've done after level of consciousness assessment and naming. Okay, sir. Tell me, what's your name?
Evan Fields,
And where are you right now?
Oklahoma City at the OU Medical Center.
Good. And what's the date today?
It's March 26, 2021.
Good. You got all 3 right. We just asked those 3 things: name, location, and date. Now, if people don't know the exact date because they're not looking at their phone or their watch or something else, then that's okay, as long as they're near the right date. They can say beginning of the month, middle, end of the month. They should know the month for sure, and they should know the year for sure.
Tips and pearls for mental status orientation. Assess orientation only after assessing naming, and assess orientation to person, place, and time. Recalling the exact date is sometimes difficult for patients with normal mental status, so accept the year, month, and perhaps beginning, middle, or end of the month. Disorientation with normal language function usually occurs in the setting of true confusion due to delirium or dementia as a result of bicerebral dysfunction. The inability to name oneself, apparent disorientation to person, only occurs in patients with aphasia or profound encephalopathy or dementia. It does not occur with isolated amnesia.
Now let's test visual fields. Now, visual fields is actually one of the easiest things to test for a neurologist and somehow one of the hardest things to test for non-neurologists. So let's understand what we're doing here. The patient's visual fields are like an ice cream cone. They come out like this, and then there's a curve to them. It actually is nonsensical to test visual fields too far out. All you care about is identifying problems in the 4 quadrants in each individual eye, okay? And because there's a curve to the top, if you go out too close, the patient doesn't see these at all, and he may not see them unless you curve the hands. So it's easier to forget all that and just stay farther back and stay flat, and you want to be just below your chin and just above your eyebrows, okay? Okay, and only have the patient count fingers 1, 2, and 5. Normal people sometimes cannot distinguish fingers 3 and 4, so don't use fingers 3 and 4. 1, 2, and 5. Okay, so again, cup your left eye for me. There you go, perfectly. Make sure you can't sneak a peek in the side there. Look at my nose, and how many fingers do you see?
2, 5,
Good. Look at my nose. How many fingers do you see?
1, 5,
Good. Now the other eye. Look at my nose. How many fingers?
5, 2, 1, 5.
Good.
Tips and pearls for eyes, visual fields. First of all, do not cover your own eye when performing visual field testing. It may confuse you and it is not necessary. Also, realize that each eye's visual field is shaped like an ice cream cone. Looking at the cartoon on this page, keep the 4 quadrants in tight, close to the midline at the top of the ice cream cone, with your hands flat to the patient and your fingers either just above your eyebrows or just below your chin. Use only 1, 2, and 5 fingers when assessing finger counting. Do not stand too close to the patient. Ask the patient to cover one eye gently, cupping to avoid compressing the eye, and slant it along the nose to avoid peaking, though in patients with known brain disease, you may perform once with both eyes open. Monocular visual field deficits are usually due to retinal disease or optic nerve disease. Homonymous visual field deficits, that is to say, the same in both eyes, are due to contralateral posterior brain lesions in the temporal, parietal, or occipital lobes.
Now let's assess extraocular movements. And for the purposes of the essential neurologic exam, we just wanted to look at a cross, all the way to the left, all the way to the right, up and down. So, and I think the best way to do this is to put your fingers on his chin as a subliminal message not to move his head. Otherwise, the patient moves the head around, and you want them only to move the eyes. So, sir, look at my finger. Look at primary gaze first. Okay, sir, don't move your head, just your eyes, and follow my finger all the way. And you want to make it go all the way out so that he buries his sclera. The white part goes away. And then go all the way to the other side, and you see that he buries his sclera on the right. Now, you're going to go back to the middle, check primary gaze, check up gaze all the way, then down gaze. And sometimes you need to lift the eyelid so you can see properly. Now, it's very important to realize that in the essential neurologic exam, we're looking at only the cross. But if somebody has double vision, if their symptom is diplopia, double vision, then you must do more than the cross. You do the cross, and you also go into the corners, the so-called H, okay? That is, however, only important if the patient has symptoms of double vision, diplopia. If they don't have those symptoms, then it's best in the essential exam just to do the cross.
Tips and pearls. Eyes, extraocular movements. First, observe the eyes in primary gaze, looking straight ahead. Then check the 4 main directions of gaze, up, down, left, and right in a cross, touching the patient's chin to ensure the head does not move. Only check the cardinal positions of gaze, the so-called H, if a patient complains of double vision, which is also known as diplopia. Note that in the screening and neurologic exam, you just, in the cartoon it shows you, just check up, down, left, and right. When you have double vision, you're going to have to not just do left and right, but upper right, upper left, down right, down left. When assessing gaze, always bury the sclera, the white part of the eyes, completely in all directions to ensure the eyes move completely in all directions of gaze. If the patient is below you, you may want to lift the eyelids to visualize the patient's down gaze. Disconjugate gaze. Dis means abnormal, conjugate means conjoined, so abnormally joined. These are misaligned eyes, cause diplopia, and are due to extraocular muscle weakness, often due to cranial nerve 3, 4, or 6 dysfunction.
Now let's assess facial sensation. And you want to stay relatively medial. So the forehead medially, over the cheeks, and over the chin medially. If you go too far out, you're not in the trigeminal nerve dermatome. Let's start with light touch. Now, when you're assessing light touch, you want to have a very light brush with your fingers. Very light brush. You don't want to tap. Tapping is not good. That stimulates sensory fibers underneath the skin, and you only would test the skin. So, sir, and you have the patient close her eyes. Close your eyes, sir, and tell me, with light touch, you need to ask where I'm touching. Sir, where am I touching you?
Left forehead,
Now where am I touching you?
right forehead,
Is it the same on both sides?
yes.
Every time you test sensation, you must ask, is it the same in a perceived normal area to a perceived abnormal area? And since most patients who come to a neurologist might have brain problems, we're mainly looking at left versus right, okay? Keep your eyes closed, sir. Where am I touching you?
Left cheek,
Now?
right cheek,
Is that the same on both sides?
yes.
Excellent.
Left chin, right chin,
Same both sides?
yes.
Tips and pearls. Sensation, light touch face. All sensory testing involves comparing two different areas. For example, right versus left or distal versus proximal. In the screening neurologic exam, after similar stimuli on each side, always ask, is it same both sides? When testing light touch, lightly stroke the skin, do not tap, and ask, where do you feel it? For facial sensation, test on either side of the midline in each of the three trigeminal nerve dermatomes, V1 over the forehead, V2 over the cheeks, and V3 over the chin.
Now we'll do sensation on the body. And we want to test in the body the backs of the hands and or even the fingers. More distal the better. And the backs of the feet or toes. The more distal the better. Why? Because most conditions in neurology will affect distal more than proximal sensory loss. So if patients have normal distal sensation, you don't have to worry about the proximal. And it's really important not to over-test in sensation. You don't want to say, where am I? Just stick to 4 basic areas when you're doing the essential exam. But backs of the fingers, backs of the toes. So let's start with light touch. And once again, you ask with light touch, where am I touching you? And you go very light little brush. Close your eyes. Close your eyes, sir. Where am I touching you?
Left hand, right hand,
Are they the same both sides?
yes.
You have to ask that or you didn't do the sensory exam because you can have a relative sensory loss, right? You might have partial sensory loss on one side and not tell you, well, I feel it, but is it the same? You have to ask, is it the same both sides? Now let's do the toes. Where am I touching you?
Right toe, left toe,
Same both sides?
yes.
Tips and pearls. Sensation, light touch body. When assessing sensation in the limbs on the screening and neurologic exam, test the back of a finger on each hand and the back of a toe on each foot. Do not waste time with superfluous testing. Keep the patient's limbs uncrossed and eyes closed. Do not touch the patient elsewhere when testing sensation. When testing light touch, lightly stroke the skin, do not tap, and ask, where do you feel it? In the screening neurologic exam, after similar stimuli on each side, always ask, is it same both sides? All sensory testing involves comparing two different areas. For example, right versus left or distal versus proximal. For simplicity's sake, in the screening neurologic exam, assume we are looking for brain dysfunction comparing left and right.
Now let's assess facial strength. And so we're looking for 3 areas mainly: the forehead wrinkling, the widening of the palpebral fissures, where the eyes are, and the nasolabial fold. You want to see symmetry. So you look at the patient, and he has normal symmetry. The eyes are open about the same amount. The forehead, the mouth, all looks good. Now, you first say, sir, raise your eyebrows as high as you can. And you see the wrinkling on both sides is equal. Excellent. Then you say, close your eyes as tight as you can, sir. And you want to close them tight, and you want to say, don't let me open them. And I can't open them. He's got strong eye closure. Then you say, sir, smile for me. And you can see the nasolabial fold on each side increases equally on both sides and goes up at the same time. If one side were weak, then maybe one side would go up faster than the other each time, or wouldn't go up at all. That would be a facial weakness.
Tips and pearls. Motor coordination upper, facial strength. First, observe the palpebral fissures, that's the eye openings, and the nasolabial folds, the crease between the nose and the lip, for asymmetry at rest and during conversation. Then, ask the patient to smile, raise eyebrows, and close eyes tightly. Weakness of the entire side of the face, in which a patient is unable to wrinkle the brow, unable to close the eye, and has a flat nasolabial fold, is due to ipsilateral facial nerve, that's cranial nerve 7, palsy. Weakness of only the lower face with mild eye closure weakness and flat nasolabial fold, but normal wrinkling of the brow, is due to contralateral brain lesion.
Now let's assess pronator drift or arm drift. So put your arms in front of you, sir. You're going to have the arm like holding a big platter, palms up, and close your eyes, sir. And you want to watch for the hands. That's very good, sir. He's normal. If he were abnormal, weak a little bit in the arm, he would have had a little twisting. That's called pronation or drift down. Either one. Starts with pronation, then drift. That tells you there's weakness, a corticospinal tract problem in the arm.
Tips and pearls. Motor coordination upper, arm drift. Test arm drift with the patient's eyes closed and palms up, like the patient is holding up a platter. Look for pronation, that's twisting of the hand with the pinkies going downward, or downward drift of an arm is a sign of weakness. If the patient is supine, realize that gravity may cause a weak arm to drift toward the patient's head. So when examining patients in bed, it is best to have the head elevated somewhat to improve assessment of arm drift.
Now let's assess fine motor movements or finger tap. This assesses weakness in the fingers. So sir, I want you to go like this, take your fingers and go as wide as you can and fast, 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 tap, 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 tap. Okay, you want to see width and you want to see speed. Normal width and speed, and you want to look at both at the same time to compare. If one were slower and smaller than the other, that's weakness, and that side is slower and smaller. But he had normal strength in the fingers.
Tips and pearls. Motor coordination upper, finger tap. Have the patient tap the index fingers and thumbs together in both hands simultaneously as wide and fast as possible and look for differences. Small or slow excursions suggest weakness in the hand. This test substitutes for testing grip strength, which has poor inter and intra-rater reliability.
Now let's assess coordination in the upper extremities and lower extremities. That's finger to nose testing and heel to shin testing. So let's understand what the cerebellum does. The cerebellum in the back of the brain, underneath the brain and behind the brain stem, is the coordination center. It makes sure that the agonist muscles and the antagonist muscles are coordinated, that they're speaking to each other. For example, if you want to contract your biceps, the agonist muscle, you need to make sure the antagonist muscle, the triceps, is not contracting. And that's what the cerebellum does. It makes sure that one is relaxing while the other one's contracting. Okay? Now, if the cerebellum is not working, if there is a problem with the cerebellum, then there's a discoordination or a dys coordination, abnormal coordination, or an abnormal ataxia, dystaxia. Taxia is coordination. So that patient then has what looks like a tremor. So we often call that an intention tremor because it happens when you're trying to use the arm, but really it should be better described as an ataxia or dystaxia of a limb. Now when you're assessing ataxia or coordination, you're assessing a couple things. Smoothness of movements, that's the coordinations part, and do they hit their target? Do they hit their target? It takes more coordination to go at the end to hit your target. So you want to, and that's called metria. So when it's abnormal, it's called dysmetria. So you're looking for dystaxia and dysmetria, not hitting the target. Okay, let's start with finger to nose. And the eyes are open, and you say, sir, touch my finger with one finger. Touch your nose with the same finger. Go back and forth as fast as you can. And pull out a little bit, stretch it a little bit, and you can see that he stays accurate. Now the other side, sir. Beautiful. And he touches it accurately.
Tips and pearls. Motor coordination upper, finger to nose testing. Observe both dysmetria, that's inaccuracy or missing the target, and dystaxia, which is uncoordinated or choppy movements, such as an attention tremor. Assessing speed is not important. Coordination is considered normal if a limb is weak and moves slowly yet smoothly and accurately. It's the smoothness and accuracy that counts. Abnormal coordination of a limb with ataxia, which means ataxia or dystaxia, is often due to dysfunction of the ipsilateral cerebellar hemisphere or pathways. The cerebellum facilitates communication of agonist and antagonist muscles, ensuring the antagonist muscles do not contract when one wishes to use an agonist muscle. Dysmetria and dystaxia are a result of concurrently contracting agonist and antagonist muscles. On finger-to-nose testing, detect subtle ataxia by fully extending the patient's arm.
Now let's assess strength in the legs. Now when a patient is in bed here, we want to have the patient stabilize himself on the side of the bed, okay? And you want to say, lift, we're now assessing hip flexion. And to do that, say, lift your leg. Lift it up, sir. Don't only push. Good. Now the other one. Don't only push. Now if he were seated, it'd be a different direction. You wouldn't say lift your leg. You'd say lift your knee. If he's seated, lift your knee, right? But in the bed, it's lift your leg, and it's same both sides.
Tips and pearls. Motor coordination lower, hip flexors. Ask the supine patient to lift one leg. Push down against resistance with your dominant hand. Ask the seated patient, such as shown in the video below on this screen, to place both hands on the sides of a chair for stability and lift one knee. Instead of saying lift one leg, say lift one knee, as shown in this video. Push down against resistance with your dominant hand.
Stabilize yourself. Always have him stabilize himself first. And then you say lift your knee. Remember the hip flexors were lift your leg. Now it's lift your knee. Lift your knee, don't only push. Good. The other one, don't only push. Good. Now we're going to test the strength in his ankle. Okay? So we're going to test both dorsiflexion and plantar flexion. Start with dorsiflexion. Put your toes all the way back, sir, and you stabilize at the joint, ankle, and you pull. Don't only pull. Excellent. Then your other side. Don't only pull. Now remember, once again, even though it seems more convenient, don't pull together. If you pull at the same time, you're testing multiple muscles, and you're not isolating the muscles you want to test. It's always stabilize a joint, side to side.
Tips and pearls. Motor coordination lower, ankle dorsiflexors. Stabilize a joint, side to side. Always stabilize a joint you're testing and test side to side. When assessing the ankle dorsiflexors, stabilize the ankle. Ask the patient to point toes back toward your head and resist your push. Push the back of the foot. After testing one side, immediately test the other side for comparison. The anterior tibialis muscle dorsiflexes the ankle. It is best to stabilize the joint with your non-dominant hand and test strength with your dominant hand.
Now let's assess coordination in the lower extremities. That will be heel to shin testing. So put your legs straight, sir, for me. Okay. Now, this is a confusing command, so it's best to show the patient. With your heel, sir, let me do this for a second. I'm going to take your heel, and I want you to put it up in the air, and then down on your knee, and then run it down the shin. Okay? Up and back once like that. Okay? And then we'll do the other side. You ready? Okay, now, with this to heel, touch up in the air, heel and knee, run it down the shin. And you see it's smooth and hits the target. Okay, put it down. Now the other leg, up in the air, now on the knee, and look, it hit the knee perfectly, and then it went down smoothly on the target. Normal heel to shin testing, normal cerebellar dysfunction, normal coordination in the legs.
Tips and pearls. Motor coordination lower, heel to shin testing. As in finger to nose testing, observe both dysmetria, inaccuracy or missing the target, and dystaxia, uncoordinated or choppy movement such as an attention tremor. Abnormal coordination of a limb is also known as ataxia or dystaxia and is often due to dysfunction of the ipsilateral cerebellar hemisphere pathways, and the cerebellum facilitates communication of agonist and antagonist muscles, ensuring antagonist muscles do not contract when one wishes to use an agonist muscle. Dysmetria and dystaxia are a result of concurrently contracting agonist and antagonist muscles. So on heel to shin testing, detect subtle ataxia by first observing for dysmetria. Ensure the heel hits the knee before moving down the leg. Please note, in a seated position, one must have the patient stabilize himself, then lift the leg you are not testing. You lift the leg you are not testing so that it's parallel to the ground. This prevents the tested leg from simply falling down due to gravity, as demonstrated in this video.
Now let's assess gait and station. So first of all, let's have the patient, help the patient off the bed. Come over here, sir. Swing around. There's a stool here. Get down. Thank you. Stay near the patient. Walk over here, sir. Stay near the patient in case he has problems. Okay, stand right there, sir. Now, I want you to walk normally from there to there. And come back a couple times. Okay, turn around. Stay near the patient in case he has normal gait. Now stop 1 second, sir. What we're looking for in gait is the size of the steps. Do they outdo each other? In abnormal gait, small steps would be not exceeding each other. He has exceeded each other, first of all. Second of all, we're looking for the base. So there's really no such thing as too narrow base. Normal people cross over a little bit. If you'll notice, when I walk with my legs straight, it looks weird because that's not how we walk. We walk with our legs crossed over a little bit, right? And so they're looking at narrowness. If it's wide, a wide base often means a cerebellar problem, a coordination problem. Truncal ataxia is associated with that. The other thing you're looking for is arm swing. So the arms move together, because like a normal person. So if one arm is not moving, then one of two things is happening. Either they're weak in that arm, or they have Parkinson's syndrome. Parkinson's disease leads to rigidity and less arm movement, and weakness leads to less arm movement. So you're looking at arm swing. And you're looking at posture. Is he bent over, or is he standing straight? So posture, width of the base, size of the steps, and arm swing. Let's do that again. Walk normally, and you see the normal, everything's normal. Posture, the base, walk back, sir, the steps of are normal size, etc. Excellent.
Tips and pearls. Gait and station, regular gait. Do not test gait in socks on hard floor. Socks are too slippery. Shoes or bare feet are actually preferred. Always stay near the patient when assessing gait in case the patient has imbalance or falls. And during assessment of regular gait, observe step size, base width, arm swing, and posture. Parkinsonism is associated with small steps, decreased arm swing, and stooped posture. Cerebellar dysfunction, especially midline cerebellum or vermis dysfunction, is associated with wide-based gait, and arm weakness is associated with decreased arm swing.
The last thing we're going to assess is the Romberg test. Now, the Romberg test, it tests actually proprioception. A lot of people think it tests cerebellum. It doesn't. So let's explain something. The cerebellum has 3 sensory inputs: vision, vestibular, and proprioception, transposition sense. In order for the cerebellum to work, it has to have 2 out of 3 of those sensory inputs. Okay? Vestibular, proprioception, vision. Now, if I ask him to put your feet together, I gotta stand with my arms right here, but ready to catch him in case he wobbles, and you look for his eyes open. Now, if he wobbles with his eyes open, you don't say the Romberg test was positive. You say, what kind of test Romberg test? Because the patient wobbled with the eyes open, cannot test. The Romberg is specifically with the eyes closed. So let's watch. Close your eyes, and I'm ready to catch him, but he's not moving, he's fine. Don't push the patient, just watch him and be ready to catch him. Open your eyes, sir. So here's the point. By eliminating the vision, all he has left is vestibular and proprioception. They must both be intact. If he had proprioception out or vestibular out, either one, he would have been wobbly. The vast majority of cases, when you're testing Romberg, you're really testing the proprioception in the feet. If there are things like diabetic peripheral neuropathies or spinal cord problem, etc. Because if you have a vestibular problem, you usually feel dizzy, vertigo, etc., and you know it's a vestibular problem. So most of the time, you're testing proprioception when testing the Romberg test.
Tips and pearls. Gait and station, Romberg test. Once again, do not test gait and station in socks on a hard floor because socks are too slippery and shoes or bare feet are preferred. Always stay near the patient when assessing Romberg test in case the patient has imbalance or falls. For Romberg testing, ask the patient to stand with legs together. Observe if the patient is unsteady or falls with eyes open. If so, if the patient falls or is wobbly with eyes open, do not proceed further. And document that the Romberg test was untestable. because the patient fell with eyes open. The Romberg test is only valid when the eyes are closed. If the patient is steady with eyes open, then you may ask the patient to close the eyes and be ready to catch the patient if necessary. The Romberg test is positive if a patient is unsteady or falls with feet together and eyes closed, and signifies proprioception deficit or less commonly vestibular deficit. Never push or pull a patient when testing Romberg. In summary, the screening neurologic exam is a quick exam without tools. It is designed for non-neurologists to perform as part of a general exam on patients with or without suspected neurologic disease, and for neurologists to perform on all return neurologic patients with previously normal essential exam, a more comprehensive exam. We have rearranged the order from the traditional order of the components to make it more time efficient. There are 15 total items. It should take you no more than 2.5 minutes, and there are no tools involved. I hope you have been able to accomplish the learning objective that after viewing this presentation and practicing the screening neurologic exam with feedback from an instructor, you are able to perform a screening neurologic exam in less than 3 minutes using proper technique and, if necessary, a pocket card as prompt. This is the end of this presentation, a production of DLGINSITE, innovative neuroscience ideas and thoughts on education.